Welcome to MyPatchLink.com's video series on allergic versus irritant contact dermatitis. In this video, you will learn about the difference between the two, its symptoms, clinical course, and morphology.
Hi, my name is Dr. Jean-Marie Lachapelle, and I am going to speak to you today about the difference between irritant and allergic contact reactions. This can be a major clinical problem since there is no definite clue allowing a clinician to distinguish the two conditions. They do share similar signs and symptoms. Most allergens share both properties, irritant and allergic. Irritant contact dermatitis is presently considered the prototype of the innate immunity, whereas allergic contact dermatitis is a prototype of the adaptive immunity. Therefore, throughout this video, I will summarize some major clinical differences between allergic contact dermatitis and irritant contact dermatitis. To begin, I will discuss the definitions of both.
What is ACD?
Allergic contact dermatitis, or ACD, is a T-cell mediated delayed hypersensitivity induced by a contact allergen. Typical symptoms of the reaction may include severe itching or pruritus, redness, swelling, flaking, and peeling. Some patients may experience fluid-filled blisters or vesicles.
What is ICD?
Irritant contact dermatitis, or ICD, is caused when exposure to a substance chemically or physically abrades the skin, often inducing burning, stinging, erythema, soreness, and pruritus. Now, let us discuss the clinical differences of both ACD and ICD.
What is the clinical course for ICD and ACD symptoms?
Acute ICD may appear during the first exposure, especially with strong irritants, while a sensitizing exposure is required for ACD. Once sensitized, lesions may appear after subsequent exposures to the antigen to already primed memory T cell. In acute ICD, lesions appear rapidly, usually in minutes, to a few hours after exposure. However, delayed irritant reactions do occur. With ACD, lesions usually appear 24 to 72 hours after exposure, but may develop as early as 5 hours and as late as 7 days. Irritant reactions are characterized by the decrescendo phenomenon, with the reactions peak occurring early and tapering off. With ACD, the crescendo phenomenon is key, and the resolution of the response is usually slower.
What is the morphology of ACD and ICD?
Acute ICD includes erythema and edema, and sometimes vesicles or bullae, oozing, and pustules. Necrosis and ulceration may be seen with corrosive materials. Subacute ICD is characterized by hyperkeratosis, fissuring, glazed and or perhaps a scalded appearance of the skin. Lesions are circumscribed to the contact area, and there is usually an absence of distant lesions. In ACD, pustules, necrosis, and ulceration are rarely seen. Intense vesiculation increases the suspicion of ACD, but may not be present in chronic ACD, and clinical lesions are stronger in the contact area, but not well defined. More sophisticated methods used in laboratory can make a distinction between the two conditions. Open test, semi-open tests, and rote tests are very useful for discrimination.
What are these tests?
Open test means that a product, as is, or dissolved in water or some solvent, is dropped onto the skin and spread freely. It is generally recommended when testing is done with unknown products. For instance, if the patient brings in his or her own products. Semi-open tests follow the same method as open tests, but the product is covered by a non-occlusive tape when the products have dried off. It is useful when testing for industrial and or domestic products. It makes it easier to distinguish between contact allergy and irritation. Rote tests stand for repeated open application tests. Test substances are applied twice daily for 7 days to the upper arm, antecubital fossa, or backside. The patient is asked to stop the application of the test when a reaction occurs. This test can be useful for comparative studies. For example, comparing a scented product on one side versus an unscented product on the other side. Nevertheless, the patch test remains the gold standard for investigating cases of presumable allergic contact dermatitis. But when reactions are scored positive, negative, or questionable, there is a need to be vigilant, considering the possibility of an irritant contact dermatitis. I hope you found this video helpful, and I wish you success with your practice.
For additional information, please visit mypatchlink.com/resources.